2024. This meeting is being relayed live at more than 20 locations across India. We welcome all our speakers and delegates who have joined today at different parts of India for this academic feast. Our goal today is to discuss the numerous challenges posed by cardio-kidney metabolic disease and the role of SGLT in tackling these challenges. By focusing on this interconnected disease, we aim to enhance our understanding about management and prevention of this deadly complication associated with diabetes with the use of SGLT2 inhibitor. And to guide us today, we are privileged to have with us eminent expert in the field, Dr. Silvio Inzuki, whose vast experience in the field uh, of managing cardiometabolic kidney disease and its complication add immense value to our discussion today. Dr. Inzuki is a professor of medicine at the Yale School of Medicine. He also served as a clinical chief of the section of endocrinology and medical director of the Yale Diabetic Center. He has authored more than 500 manuscripts, chapters, monographs, and abstracts, some of them published in most prestigious medical journals such as NEJM and JAMA. He is also former editorial board member of the Diabetes Care and associated editor for the Journal of Clinical Endocrinology and Metabolism. He served as co-chair of the ADA ESD position statement on the management of hyperglycemia in type 2 diabetes. He is also a recipient of the 2021 ADA Outstanding Physician Clinician in Diabetes Award and Yale's David J. Leffel Prize for Clinical Excellence, and many more in the list. He has held leadership roles in several large clinical trials related to diabetes, medication, and their cardiovascular impact. He has been an invited lecturer both nationally and internationally on many topics most pertinent to clinical diabetes management. And he's going to deliver his talk on SGLT inhibitor. How did this glucose lowering drug become cornerstone of CRM therapy? So with this word, I hand over the podium to Dr. Silvio sir and request him to guide us how we can use this molecule to enhance outcome in diabetic patients. Over to you.
Thank you very, very much. I'm going to share my screen now. Hopefully you can see my slides. So again, I was asked to review the data behind the SGLT2 inhibitors and talk a little bit about their history and where they fit in terms of treating patients with cardiorenal metabolic conditions. So very happy to be here. So let's start by reviewing the pathophysiology of diabetes. I think this is very important for clinicians who treat this disease. I remind the audience that in type 1 diabetes, the pathophysiology is relatively straightforward. There is autoimmune destruction of beta cells, lack of insulin secretion, and it's not surprising that the result is hyperglycemia, as well as the predisposition to ketosis, weight loss, and other catabolic features. Type 2 diabetes, in contrast, is much more complicated. There are multiple defects, including abnormalities in peripheral tissues such as skeletal muscle and the adipocytes, specifically insulin resistance. There are defects at the level of the endocrine pancreas with not enough insulin in the face of that insulin resistance. That is, the peripheral tissues require more insulin, and over time, the patient with type 2 diabetes is not able to sustain the hyperinsulinemia that was necessary to maintain normal glucose tolerance. There's also evidence of relative increase in pancreatic glucagon secretion, particularly in the postprandial phase, with further increases hyperglycemia. The liver is very important in this process. It's an insulin responsive organ. It produces glucose. It should be shut off by insulin. And because of the insulin resistance, the liver makes too much glucose, again, also specifically in the postprandial phase. We've learned a lot about incretin hormones over the past couple of decades. GLP-1 and GIP are the predominant incretin hormones. They emanate from the GI tract in response to meal and stimulate insulin secretion and also suppress glucagon. And those signals are deranged in patients with type 2 diabetes. And finally, and importantly for today's conversation, the kidney also plays a role. It is a glucose excretory organ. It should release glucose when the plasma glucose concentrations achieve 180 milligrams per deciliter, and in type 2 diabetes, that in the US, there are now 12 categories, or perhaps 13 if we consider the incretin coagonist tirzepatide, if we consider that to be a separate drug category from the straight monoagonists of the incretin system. To make it simple, however, we will eliminate 5 of the drugs that are not used very commonly, and basically review the 7 major drug classes that are in widespread use in the United States for the management of type 2 diabetes. I know these are also available in India. On this slide, I've listed these 7 drug categories. We have reviewed their average hemoglobin A1C reduction and specifically their mechanisms of action, which we don't have time to get into today. On the right side of the slide, we see the benefits and the risks of these medications, and at the far right, the relative costs of these medications, at least in my country. Specifically for today's discussion, at the bottom of the slide are the SGLT2 inhibitors. Here we have several available. The first was canagliflozin, the second was dapagliflozin, the third empagliflozin, and more recently ertugliflozin, and very recently bexigliflozin. I know in parts of Asia, specifically in Japan, there are at least 2, if not 3 other of so-called flozins. These, as we'll see, work by reducing hemoglobin A1C through glucosuria. In other words, eliminating glucose from the circulation into the urine, thereby improving hemoglobin A1C. The added benefits of this drug class include modest weight loss, about 2 to 3 kilos, a modest additional lowering of blood pressure, probably because of sodium losses that occur through the mechanism of action. This results in about a 4/2 millimeters of mercury drop in blood pressure. And as we'll talk about later on, there have been significant data as regards to the cardiovascular and the kidney benefits of the SGLT2 inhibitors, as these modestly reduce MACE, or major adverse cardiovascular events, and have a significantly greater effect on reductions in heart failure outcomes, specifically heart failure hospitalization, a very important outcome in older patients with type 2 diabetes, as well as in the progression of chronic kidney disease. On the negative side, patients will urinate more, so they develop, in some circumstances, particularly early on in the treatment course, polyuria. They may be predisposed to dehydration as a result if they don't keep up with their fluid intake. Genitourinary infections has been a concern, specifically genital mycotic infections, not so much urinary tract infections. Diabetic ketoacidosis, and specifically the euglycemic form of DKA, has been reported mainly in off-label use in type 1 diabetes, although it still may occur in certain individuals with type 2 diabetes if they're under significant stress and if they're very insulinopenic. In other words, they're low down on their insulin secretory capacity curve with long-standing disease. Canagliflozin was associated with bone fractures as well as with amputations, but the other SGLT2 inhibitors have not been. Now, the first SGLT2 also had some SGLT1 effect. The first inhibitor of these transporters was actually fluorescein, which was discovered a couple of centuries ago. This is a compound that is extracted from the bark and root of the common apple tree and is a glucoside. And this was first identified by 2 Belgian physicians, Professors De Koninck and Stas, who published their treatise in 1836. And it was 50 years later when the experimental physiologist, Professor von Mehring from Germany, first used fluorescein, this is now in 1886, in a canine model and induced glucosuria. And interestingly, Professor von Mehring felt that he had actually induced diabetes in these animals. And little did he know that fast forward more than a century in the future, this drug category, the father of which was fluorescein, would become such an important and popular medication to actually treat diabetes. Now, fluorescein is a very interesting compound. It actually never made it into human clinical trials, but this is a favorite study of mine back in 1987 from investigators at my institution. You'll recognize some of the names. Dr. Luciano Rossetti, who subsequently went to Merck, Dr. Jerry Shulman, who's still my senior colleague at Yale, and the famous Dr. Ralph DeFranzo, who's now the director of the Texas Diabetes Institute at the University of Texas in San Antonio. And these investigators and their colleagues were testing the notion of glucose toxicity, and that is an important concept in diabetology, whereby the hyperglycemia itself can alter both insulin secretion as well as insulin sensitivity. So patients become insulin resistant when they develop hyperglycemia, almost like a fast forward loop. And the reversal of glucose toxicity by lowering plasma glucose concentrations has the opposite effect. So beta cell function improves, and insulin sensitivity improves as well. So these investigators used the drug fluorescein because it did not alter insulin secretion and did not affect insulin sensitivity. It was purely a drug that lowered the plasma glucose concentrations and allowed the investigators to design a trial or a study that proved that reducing blood glucose with fluorescein had a major impact on reversing glucose toxicity. But again, fluorescein never made it into clinical trials. Now, it was in the 1980s and early 1990s that there was substantial investigation about these transporters in the proximal nephron. And here we're showing the transporter SGLT2. And it was first discovered or identified by Dr. Eugene Wright at the University of California at Los Angeles. And it was interesting that there were several families identified at around that time. This was the first case I could find from 1987, a 15-year-old boy who had chronic glucosuria. This is an inherited condition that was later identified as being the result of a mutation in the SGLT2 transporter. And this subsequently left to the recognition of the physiology of glucose handling by the nephron. So glucose is filtered, and the urinary glucose concentration in the proximal tubule is essentially identical to the plasma glucose concentration. And if these transporters, SGLT2 and to a lesser extent SGLT1, were not present, patients would be chronically glucosuric, and that would be an enormous waste of energy and would not be good for the organism, obviously. So as long as the urinary glucose and therefore the plasma glucose concentrations are kept under 180 milligrams per deciliter, the capacity of these transporters, SGLT1 and 2, is not exceeded, and 100% of the glucose is resorbed, and there is essentially zero glucose coming out of the urine. Now, obviously, if that glucose threshold, 180 milligrams per deciliter, or 10 millimoles, is exceeded, then there begins to be the appearance of glucosuria, which is one reason why in uncontrolled diabetes, patients have polyuria and polydipsia from the osmotic diuresis. Now, if you develop an inhibitor of that transporter, the same transporter that was defective in that 15-year-old boy, you essentially open the floodgates and allow glucose to be excreted. And the amount of glucose excretion is quite large. It's in the range of 70 to 80 grams per day, which translates to approximately 300 calories per day, which describes why patients lose weight with these compounds. So again, the healthy nephron has a glucose threshold of 180 milligrams per deciliter, or 10 millimoles. Interestingly, in type 2 diabetes, that threshold, as I alluded to in one of my first slides, is increased to 240 milligrams per deciliter. So again, the kidney is not behaving normally in diabetes. But if we use an SGLT2 inhibitor, that threshold was reduced well under the normal threshold, down to approximately 70 or 80 milligrams per deciliter. And eventually, the pharmaceutical industry became very interested in the potential use of these compounds that were similar to fluorescein, but subsequently called the SGLT2 inhibitors, or flozins. And this is one of the earliest studies, one of my favorites, comparing the combination of metformin in uncontrolled patients with type 2 diabetes, adding dapagliflozin versus adding the sulfonylurea glipizide. And you can see, while initially the dapagliflozin molecule seemed less effective than glipizide in lowering hemoglobin A1C, by the end of the first year, the hemoglobin A1C decline was identical. And the benefits were weight loss with dapagliflozin versus weight gain with glipizide, and certainly more hypoglycemia with the sulfonylurea. So the relative benefits versus risks before the cardiovascular outcomes studies were released looked something like this. This was a modestly effective medication, lowering hemoglobin A1C between 0.6 and 0.8%, a very low risk of hypoglycemia, reduction in weight and blood pressure as mentioned, some renal benefits in terms of reductions in urinary albumin to creatinine ratio, and some beneficial lipid effects as well. But as we've already reviewed, there are some side effects and adverse events, such as urinary frequency, but there was a reduction in GFR initially, which is entirely reversible, somewhere in the 5 to 10% range. But when there was initial discussions about bringing these drugs to market, there was substantial concern that these drugs could potentially harm the kidney, although, as we'll see, the opposite was actually true. Now, genitourinary infections, as I alluded to, are the major side effect, which is clearly associated with the drug category. Genital yeast infections are the predominant one, mainly in women and uncircumcised men. Urinary tract infections can occur, but in the large clinical trials, they appear to be relatively infrequent. We talked about euglycemic DKA, the fracture risk with canagliflozin, and a small increase in LDL cholesterol. But again, at the time prior to the cardiovascular outcome trials and the kidney outcome trials, which began in 2015 and 2016 in terms of their results, this was considered another glucose lowering agent with some additional benefits, but we did not know at the time how extraordinary those overall benefits would eventually be. Our group presented the EMPERIC outcome trial results in late 2015 at the European Association for the Study of Diabetes meeting in Stockholm, Sweden. And here, for the first time, we reported a beneficial cardiovascular effect from a glucose-lowering medication, never previously reported. There was a 14% relative risk reduction in MACE, major adverse cardiovascular events, which is the trio of non-fatal MI, non-fatal stroke, and cardiovascular mortality. This was not a huge effect, admittedly. Many of the statin trials and blood pressure trials from the 1990s and early 2000s would report MACE effects in the 20 to 30% range or slightly more. But again, this was a notable finding because of the specific drug type, in other words, a glucose-lowering agent, and the specific type of patient, which was a high-risk individual with type 2 diabetes. The component of MACE that was most dramatically reduced, with a 38% risk reduction, was in fact cardiovascular mortality. And interestingly, there was this early divergence of the event curves, such that by 3 months there was already a separation between the groups. And finally, heart failure hospitalization was also significantly reduced. This was a secondary outcome, about a 35% risk reduction, and an even earlier divergence of the event curves. So after EMPA-REG, there were a series of other cardiovascular outcome trials with other SGLT2 inhibitors, including dapagliflozin and declared TIMI58. And you can see that across the drug class, the mean reduction in MACE is, again, modest, about 10% relative risk reduction, a larger effect seemingly on cardiovascular mortality with a 15% relative risk reduction. And in this meta-analysis, there was more consistent effect across these 5 trials for heart failure hospitalization, here showing a pooled estimate of a 32% relative risk reduction. So these findings led the cardiovascular community to wonder whether the SGLT2 inhibitors could be a heart failure therapy, and importantly, whether the benefits of the SGLT2 inhibition required glucose lowering, i.e., could they help patients who had heart failure but did not have diabetes. So quite rapidly, a series of heart failure trials were put together, both in heart failure with reduced as well as preserved ejection fraction, so HFrEF and HFpEF. And remarkably, the relative risk reductions were significant across the spectrum of left ventricular ejection fraction. This is unique to this drug class because, as many of you know, several therapies that have clear effects in HFrEF. Studies, heart failure, hospitalization, and cardiovascular death were the primary outcomes. And you can see that the pooled estimate for the heart failure effect was 23%. Again, no heterogeneity as related to the degree of LV dysfunction, and also no heterogeneity regarding the presence or absence of diabetes, meaning that you don't have to have diabetes to benefit from a heart failure standpoint from an SGLT2 inhibitor. This is a more recent meta-analysis that pools all the data from the cardiovascular outcome trials, from the heart failure trials, and as we'll see from the renal trials. This is the MACE composite, now in the same range as we saw previously of about 9%. Cardiovascular death, about 14%. And myocardial infarction not significantly reduced, nor stroke. I alluded to the renal outcomes, and here we see from EMPA-REG a 39% reduction in the progression of CKD. This was also gratifying to see because, as mentioned, some experts had wondered whether there might be a worsening of renal outcomes in. And here is now the meta-analysis for the renal studies, the renal component of the cardiovascular outcome trials. We can see that both with EMPA-REG as well as DECLARE and dapagliflozin and the other trials, with the exception of VERTIS-CV, there was a statistically significant reduction in the risk of progression of CKD. Some of these outcomes included macroalbuminuria, whereas some looked specifically at the doubling of creatinine or the halving of the
Mm. So you need to unmute, sir. Dr. Silvio, please unmute yourself, sir.
I think I'm back on now.
Yes, sir.
Okay, sorry about that. We had some connectivity issues here. So the renal outcome trials were next, and the same question was being asked by nephrologists as were the cardiovascular experts. Would the SGLT2 inhibitors benefit patients with CKD, irrespective of the presence or absence of diabetes? And very similar to what happened with the heart failure trials, the CKD trials were rapidly put together, and specifically with DAPA-CKD and dapagliflozin and EMPA-KIDNEY with empagliflozin showed significant reductions in the progression of CKD. Now, in contrast to the CV outcome trials that I showed you a couple of slides ago, these data did not include macroalbuminuria in the outcome. In other words, these were hard renal outcomes. As I mentioned before, the doubling of serum creatinine, the halving of GFR, the development of end-stage renal disease, et cetera. Although when they looked at macroalbuminuria, it was decreased, but it wasn't part of the main clinical outcome, because that's considered a softer outcome by a nephrology clinical trialists. So we favor the SGLT2 inhibitors in patients with heart failure, in patients with CKD, and patients with cardiovascular disease, the so-called CRM conditions, a cardiorenal metabolic syndrome, as well as in patients with just type 2 diabetes and obesity because of the weight loss, although admittedly the GLP-1 agonists are much more effective in body weight reduction than the SGLT2 inhibitors. And in some circumstances, although the cost is significantly high, we might use them in combination. It's also important, obviously, in clinical medicine to know when to avoid these medications. So individuals that had recurrent genitourinary infections, people with chronic instrumentation of the urinary bladder, I think these drugs should probably be avoided because you might be asking for trouble. Certainly, they're not approved in type 1 diabetes, but patients who have latent autoimmune diabetes of adulthood, or LADA, which is sometimes confused with type 2 diabetes, may also be predisposed. So I would have some caution in using this drug class in that individual. Orthostatic hypotension, the frail elderly, I put a question mark here because studies to date actually show, based on frailty score, that patients with the greatest frailty still benefit from the drug class and actually don't have an increase in side effects, although I think we need to individualize. And then with the canagliflozin data, many of us still have some concerns whether there could be a predisposition to amputations with SGLT2 inhibitors, although I would emphasize again that there is zero evidence for that other than with canagliflozin. In terms of tips to using this drug category, we tend to adjust the other diuretics based on the volume status. We also adjust insulin and sulfonylureas if the patient was already under tight control to avoid hypoglycemia. We do tolerate small decreases in GFR. In fact, the nephrologists say that we shouldn't actually measure the GFR other than routinely after starting these medications. Remember that the duration of action is more than 24 hours. So if the patient misses a dose, it's perfectly fine to simply resume the next day, not necessarily double the dose. We do hold the medication 3 days prior to surgery, and this is to avoid euglycemic decay, which has been reported rarely in the postoperative period because of the stress. We also hold it during moderate to severe illnesses, even if the patient is not in the hospital. And we discuss genital urinary infections and its treatment in all patients starting these medications, because that's the most common side effect in addition to polyuria. And the two more popular flozins in the United States are DAPA and empagliflozin, and each of those are dosed at 10 milligrams per day. So to conclude, I wanted to look at the history of treatment of diabetes over the past few decades. And we know that insulin has been out since the early 1900s. Sulfonylureas since the early 1950s. And then metformin in the United States only became available in 1995, the thiazolidinediones in 1997, the GLP-1 agonists in 2006, and the DPP-4 inhibitors in 2007. We did not have the SGLT2 inhibitors until 2013, 2014. And again, the most recent drug class, the co-agonists, became available in 2023. So these are the major clinical trials that drove some of our guidelines, the UKPDS showing an important benefit in terms of glucose reduction on microvascular risk. But disappointingly, in 2008, 2009, the essentially negative results of ACCORD, ADVANCE, and VADT indicating that glucose control alone was insufficient to reduce the more common complications of diabetes, which are obviously cardiovascular disease. Regulatory agencies, including the US FDA, began to insist on large clinical trials to demonstrate cardiovascular safety in 2008, 2009, and a series of trials, including EMPA-REG and DECLARE with empagliflozin and dapagliflozin, were released anywhere between 2015 and 2019. And this drove the recommendations to favor the SGLT2 inhibitors in certain types of patients. The era of expert opinion essentially ended in 2018 when the guidelines changed. These are the older guidelines from the American Diabetes Association and the EASD, suggesting that metformin would be foundational therapy, followed by the A1C-driven approach, meaning that if the A1C is not adequately controlled, to essentially add one of these additional agents without any regard to cardiovascular impact or renal impact, simply striving for A1C control. And that was merely because there weren't any data at the time in 2015 when this guideline statement was put together that any one drug versus another had a specific benefit on the cardiovascular system or the kidney. So we would move from monotherapy to dual therapy to triple therapy and ultimately to combination injectable therapy, but again, without regard to cardiovascular impact. We were very, very glucocentric at the time, all decision points driven by hemoglobin A1C. Now, with the cardiovascular outcome trials, beginning in 2018, we entered a new age of diabetes treatment, which is the evidence-based medicine age, where we actually have convincing data from the SGLT2 inhibitor field that these drugs should be preferred in patients with CVD, with heart failure, and with CKD. Now, of course, there are additional trials that were driven by the FDA guidance for cardiovascular outcome trials from the field of the incretin treatments, in other words, the GLP-1 agonists that have additional trials indicating a specific benefit of those medications on patients with cardiovascular disease. So just quickly, the most recent guideline statement from ADA and EASD is quite straightforward. If a patient has ASCVD, then either a GLP-1 or an SGLT2 inhibitor should be favored as initial therapy, not necessarily starting, interestingly, with metformin as foundational therapy anymore. The heart failure patients would be assigned SGLT2 inhibitors, as would the patient with CKD. So finally, the evidence-based era is compelling specific channeling of certain patients to certain drug categories, again, based on the data from the clinical trials that we reviewed. So to summarize, the SGLT2s are modestly effective glucose-lowering agents available over the past decade for the management of patients with type 2 diabetes. During cardiovascular outcome safety trials, interesting signals emerged that these drugs reduced cardiovascular death, heart failure hospitalizations, and the progression of CKD in the high-risk type 2 diabetes patients that were recruited into these trials. These effects were seen as distinct advantages versus older diabetes drugs. Those ones had never been really conclusively determined to result in cardiovascular improvement, let alone renal improvement. And this discovery obviously led to many changes in our treatment guidelines. Moreover, over the past 5 years, the benefits of SGLT2 inhibition have extended to patients with heart failure and CKD with or without the presence of type 2 diabetes. So there's been a significant impact in the fields of cardiology and nephrology. And indeed, the SGLT2 inhibitors have transformed the treatment landscape in both of these areas as well as in endocrinology, but there is still much more that we need to know. And I'll leave you with just some thought provocation that we still don't understand the mechanism of action of the SGLT2 inhibitors as regards to the cardiovascular benefits. There appears to be a little bit more certainty that the renal benefits may relate to the effects on the glomerulus in terms of intraglomerular hypertension from the SGLT2 inhibitors, but that's not necessarily proven. It's just a strong contender as to the rationale. But from the cardiovascular system, it may be overly simplistic that the SGLT2s can be considered merely a diuretic. Other diuretics don't seem to have that power on reducing heart failure hospitalizations or cardiovascular mortality. But I listed here for you some of the purported metabolic and vascular or hemodynamic effects of the SGLT2 inhibitors that may either alone or in concert with others be responsible for the dramatic improvement in cardiovascular and renal outcomes that we see from this drug category. So with that, I think I'm out of time. I thank you so much for your attention. I apologize for the technical glitch in the middle of my talk, but I'd be happy to entertain any questions or comments from those listening today. Thanks again.
Thank you, Dr. Silvio, for providing complete overview of SGLT inhibitor in the management of CRM. So we have a few questions in the chat box. I will take one by one. So we have first question that how SGLT inhibitor can cause metabolic acidosis. Is there any specific reason why the metabolic acidosis can be occur with the use of SGLT inhibitor?
So I think you're referring to the diabetic metabolic acidosis, and
right.
I don't think we know for sure, but the metabolic influences of the SGLT2 inhibitors are as follows. Number one, they do lead to a little bit of fat breakdown, so they're lipolytic, so they drive the free fatty acid release from fat stores. And free fatty acids are a precursor to ketones at the level of the liver. So there's more substrate delivery, shall we say, to the liver. There's also some evidence that glucagon levels may be increased in patients who take SGLT2 inhibitors, although the time course of that, whether that's an early effect or a late effect, is not well worked out. But suffice to say that glucagon increases, especially when there is increased substrate delivery, can favor the production of ketones from the liver. Finally, there is some evidence that ketone excretion can be altered negatively in patients on SGLT2 inhibitors. So more substrate to the liver, more production of ketones, and you can't get rid of the ketones as readily when you're on an SGLT2 inhibitor. So those are the physiological effects that may predispose to diabetic ketoacidosis. Practically, however, what we see when these drugs are used in, again, off-label, I'm not recommending they're used in type 1 diabetes because it's very tricky, is what we see is that they're effective in patients with type 1 diabetes. So they lower glucose, particularly in the postprandial phase, and the patients will realize this and take less insulin. So if they reduce their insulin too much, they may not be adequately insulinized, which can compound the metabolic effects and promote more ketogenesis. It doesn't tend to happen spontaneously. It's usually an event that occurs. The insulin pump fails, the patient has a myocardial infarction or an infection and goes to the hospital. So there's usually some stress involved. But clearly the risk of ketoacidosis, which can be associated with normal glucose levels, that's why we call it euglycemic decay, not in all cases, but in more cases than we see in the non-SGLT2 inhibitor type 1 diabetes patients. These risks need to be considered. But again, these are type 2 diabetes medications, and in that circumstance, the risk of decay is extremely low.
Thank you, Dr. Silvio. So we have one more interesting questions. It is regarding to trial finding that EMPA-REG demonstrated severe death reduction benefit with empagliflozin. However, other SGLT inhibitor did not demonstrate similar benefit in the CVOT trials. If we talk about the DAPA-HF, then it has shown the severe death benefit compared to the empagliflozin. So how do you see such finding, and how to translate this finding in clinical practice?
It's a great question. We clearly got lucky in the empagliflozin trial because the cardiovascular mortality data was the strongest of all of the SGLT2 inhibitors, and honestly, that drove the MACE effect. I think if we did not have the mortality benefit, the MACE outcome would not have been significant. I actually don't think it's a difference between the drug classes. I think that the drugs are relatively similar in terms of how they affect glucosuria, et cetera. So I just think that the population that were recruited to EMPA-REG may have been sicker, it being the first trial, and everybody had to have cardiovascular disease. So each population of patients is different, but I think that's why we tend to look at the meta-analyses to give us a point estimate that is probably the most rational estimate of what the drugs can do. And as we showed you in the McGuire meta-analysis, that was published in Circulation, I believe, the point estimate was a 15% relative risk reduction. With the updated meta-analysis from the SMART-C collaborators that was published also in Circulation, or maybe Lancet Diabetes and Endocrinology, the point estimate was 0.86. So there was a 14% risk reduction. That is a larger meta-analysis that included the cardiovascular trials, the heart failure trials, and the kidney trials. So I think we're getting very consistent effects. And it's certainly probably not a 38% reduction that we saw in EMPA-REG, but closer to 15 when used across a wide spectrum of patients.
Okay, thank you. We have a question with regard to the oral semaglutide. So how do you see the metabolic benefit of oral semaglutide vis-a-vis empagliflozin 25 milligram dose? How do you see the benefit of these two molecules in diabetes management?
Well, I think in response to that question, the first question is, what does any GLP-1 agonist offer that an SGLT2 inhibitor doesn't? Obviously, they both have a MACE effect, not to split hairs, but the meta-analysis with GLP-1s shows about a 13% relative risk reduction versus a 10% relative risk reduction. I'm not sure if we compare these meta-analyses head-to-head, if that would be statistically significantly greater, but at least numerically larger effect on MACE. And in contrast to what we see with the SGLT2 inhibitors, there appears to be a larger effect in stroke, protection against stroke. So in the meta-analyses, we see about a 17% relative risk reduction with GLP-1s, whereas with the SGLT2 inhibitors, as I showed you in the SMART-C collaboration, there was essentially no effect. The hazard ratio was 0.99. So the suspicion is that the GLP-1s may be more anti-atherosclerotic versus the more hemodynamic effects of the SGLT2 inhibitors, which is why when investigators have looked at combination therapy, they appear to be additive. So it's not like one cardiovascular drug abrogates the effect of the other. They appear to be additive. I'm not saying synergistic, but at least additive. Now, your question was about oral semaglutide. And it's interesting that the sponsor of the SOUL trial just announced that SOUL met its primary outcome. This was the large 9,000 patient cardiovascular outcome trial of oral semaglutide. I don't have the specific numbers in front of me, but at least the main result was positive. In other words, the MACE effect that the study was powered for was convincingly and statistically significant. So it sounds like it's a analogous result of the other GLP-1 trials, such as SUSTAIN-6 with injectable semaglutide, PIONEER-6, which was a smaller non-inferiority trial with oral semaglutide, and the REWIND trial, which was a dulaglutide large cardiovascular outcome trial. Now, obviously, the oral form is a little bit weaker in terms of the A1C reduction versus the higher levels that you achieve with the injectable form of semaglutide. But it is a drug that certainly could be used in combination with an SGLT2 inhibitor. The issue there is cost, because at least, I'm not sure in India, but in the United States, the cost of these medications, if insurance does not cover them, most of my patients cannot afford them out of pocket. And to compound the cost with an SGLT2 inhibitor, which are still not generically available yet, is well out of the reach of most individuals.
Thank you. We have one more question. Can we use SGLT2 inhibitor in the pre-diabetic individual to prevent the diabetes? Is there any evidence which suggests that we can get more benefit when we use inhibitor compared to metformin in such patients?
Yeah, there's not a lot of studies done specifically in a pre-diabetes population or an obese population because the effects are not huge in terms of weight loss. We did an analysis that was pre-specified in the DAPA-HF trial, so dapagliflozin in HFrEF, and also in the DELIVER trial, which was the HFpEF trial, and we pooled those data together along with data from the DAPA-CKD trial. And what we showed is about a 30% reduction in the development of diabetes. Now, this was not a diabetes prevention trial, don't get me wrong, we did not do oral glucose tolerance tests. We simply took the patients who did not have diabetes, were recruited into these 3 trials. Remember, the heart failure trials and the CKD trials asked the question whether the benefit would extend to non-diabetic patients versus patients with overt diabetes, and the answer was yes. So we took that subgroup of patients, I think it was about 40% of the patients did not have diabetes, and we saw which developed diabetes based on either hemoglobin A1C or on outpatient diagnosis of diabetes during the course of the trial, which extended for 1.5 years up to 3 years. And again, we saw about a 30% risk reduction. So I believe that these medications actually do prevent diabetes. Unfortunately, a large-scale diabetes prevention trial has not yet been put together.
Thank you, sir. We have one more interesting question, that when we should stop using SGL inhibitor in terms of the challenge, particularly when patient got the genital mycotic infection, we should continue after genital mycotic infection, after when the patient is recovered, or we should stop forever using SGL inhibitor when the patient is having genital mycotic infection.
So this is the question about urinary tract infections, not genital infections.
The genital infection, with regard to genital
okay, not urinary, genital infections. There's no data. I tell you what I do is I have the patient stop and treat, usually with topical, sometimes with an oral therapy. And once they're cured of that, then I restart it. If it keeps happening, I will allow 1, maybe 2 infections, but if it keeps happening, at some point you have to have a practical approach, and the patient can't keep taking these medications on a chronic basis. In other words, the antifungal medication. So we'll resort to some other type of therapy. Other colleagues of mine treat through because, again, there's no evidence that because you're already on an antifungal, whether the glucose in the urine is aggravating that, but it's just my kind of logical approach, but it's not based on anything but clinical experience.
Very true, sir. When we are lack of evidence, we need to utilize our concerns, and we have to, yes, thank you very much. So we have one question with regard to the benefit of SGL inhibitor in NAFLD. So recently, few molecules have demonstrated benefit in the NAFLD, or we can say MFLD. So how do you see such finding, and do you think that newer guideline would advocate this as an additional point in the complication-centric algorithm?
So to my knowledge, the data are inferential at this point. In other words, I don't know of any specific trial designed to test this in a MASH population or a MAFLD population. We've done studies from our clinical trials, including EMPEROR outcome. We show improvement in some markers of MASH, such as transaminases, and the Dallas steatosis score, the DSS, seems to improve. Much of that is driven from the very mild weight loss that we achieve. I'm not sure if there's a specific effect of SGLT2 inhibition at the liver, but I do think that the indicators are that it may benefit. The problem here is that we don't have any, until recently, we haven't had any MASH therapies. The GLP-1 agonists that we've talked about before have a much more extraordinary effect on body weight, particularly with the weekly long-acting injectables, and particularly at higher doses, as we all know. So the weight contrast and the weight loss, where with the SGLT2 inhibitors, it's 2 to 3 kilos, and that's essentially all you get. Trial after trial has shown that. With the GLP-1s, you can achieve even 15 or 20% reduction in body weight. So clearly the hepatology community is much more interested in conducting trials with the GLP-1. So they haven't had enough time or resources to look at SGLT2 inhibitor trials. I would point out that pioglitazone is a drug that is less commonly used. I mentioned it in passing when we talked about the pharmacopoeia of diabetes, this being a thiazolidinedione. It's the third TZD that was out on the market, troglitazone, which was removed because of negative hepatic effects, and then rosiglitazone was removed because some suspicion through meta-analyses that it might increase the risk of myocardial infarction, although later that was refuted in a clinical trial, but the damage had already been done. The reputation of rosiglitazone soured, and pioglitazone was the last man standing, as we say in the US. So that's still available. It's generically available. I prefer it at low doses of 15 or 30 milligrams instead of 45 milligrams. Obviously, we all know the concerns. I know pioglitazone had been at one time very popular in India. I'm not sure if it still is popular. As you all know, Indian patients of Indian origin, South Asian origin, have a lot of insulin resistance, even though the obesity rates are not as severe as in the United States. The definition of obesity is very different in Asia than in Western countries. But I do think my personal experience is that pioglitazone, even at low doses, works very well as a glucose-lowering agent. It's very inexpensive. And the reason I mention it is I'm an editor for a website called Practice Update. I welcome everybody to join that website, because what we do is we review about 15 or 20 papers every week, and we post the good ones, and sometimes we invite experts to provide a little bit of commentary. So within 15 or 20 minutes, you can basically learn about all the diabetes papers for that week. And the one that I reviewed literally a half hour before I started my lecture today was a combination of pioglitazone and an SGLT2 inhibitor. I forget if it was DAPA or empagliflozin on MASH. So pioglitazone, as many of you know, was the first drug that showed an improvement in MAFLD, with actually a trend toward improvement in fibrosis, although the study didn't go long enough to actually show a decrease in cirrhosis or hepatocellular carcinoma. But I think many hepatologists have been interested in pioglitazone prior to the development of the GLP-1 agonists as the only diabetes therapy that could actually lower glucose and improve the progression of chronic liver disease. And some prescribe it. It had been in the American guidelines. I'm not sure if it's in the European guidelines, which were just updated, as a consideration, not a strong endorsement, at least a consideration. Anyway, this study looked at the combination of pioglitazone with an SGLT2 inhibitor. That is a very interesting combination, because any fluid retention that you get with pioglitazone, any weight gain that you get with pioglitazone may actually be mitigated with the SGLT2 inhibitor. So I think that's an interesting concept. It's certainly much less expensive than the new medication that was recently approved for MASH. I'm blanking on the name, and maybe even the GLP-1 agonist. So just a comment. I'm always trying to get physicians, colleagues, to not forget about pioglitazone because it's so inexpensive and so effective.
Very interesting, sir. Actually, pioglitazone also shown benefit in terms of stroke reduction as well. So maybe it will be more beneficial when we combine these two molecules together. However, in India also it did not pick up that much after the bladder cancer reports. It is not that much used extensively in India as of date. But still, we are trying to enhance the market with pioglitazone as well.
Okay.
We have one more question with regard to the dose of empagliflozin. As already trial has demonstrated benefit with 10 milligram dose, but if we look into the 25 milligram dose, it has more potential to reduce the weight. So, do you think that it will translate into more severe protection? Do you think that the 20 milligram dose will be better? What's your take on this?
I personally feel that the additional A1C reduction is very modest, 0.1 or 0.2. The additional weight reduction, my recollection of those data, it's pretty modest. It's probably less than a kilogram. I mean, once you've opened up the transporters and the glucose is coming out, whether you give 10 or 25 milligrams, the only reason I give 25 milligrams is just a cost save because it's flat pricing in the US. I'm not sure about India. So 25 is just as expensive as 10 milligrams. So in patients that don't have insurance or paying out of pocket, I sometimes bend the rules a little bit and prescribe the 25 milligrams and ask them to take half a pill a day. So that's 12 and a half milligrams, which is similar to 10. But all the cardiovascular outcome trials, well, let me correct myself. In EMPA-REG outcome, we actually used two doses. We used 10 and 25 milligrams. I forgot that. But there was no difference at all in the heart failure outcome, the MACE outcome, and the CKD outcome. Absolutely no difference. So because of that, when the cardiologists designed the heart failure trials, which were known as EMPEROR preserved and EMPEROR reduced for HFpEF and HFrEF respectively, and then for EMPA kidney, they chose the 10 milligram dose because they felt that without any compelling evidence that there's an overwhelming benefit of the 25 milligrams. So that's why in my tips and tricks slide, I just said it's very easy to remember. If you prescribe DAPA or EMPA, which are the most popular ones, it's 10 milligrams for each.
So if you allow, we can take one more last question.
Sure.
Okay. So the question is with regard to the initial dip in EGFR with azimuthal. So when we should worry about dip in EGFR?
That's a great question. I often ask my nephrology colleagues. The bottom line is that on average, you drop 5 milliliters per minute. Or let me rephrase that. You drop 5%, which is often about 5 milliliters per minute. So a 5% drop is well in the expected range. We get a little concerned when the GFR exceeds 10%. Although the nephrologists say you shouldn't stop the drug unless the GFR falls more than 20%. Now, to me, not a nephrologist, although I was going to be a nephrologist before I went into endocrinology, interestingly, to me, anything above 10% raises a little bit of concern. Now, it's true that the drop is reversible. When you stop the medication, the GFR goes back to normal. And it's also true that when you look at the renal outcomes as well as the cardiovascular outcomes in those patients that what I call are big dippers, in other words, their GFR dipped more than usual, they appear to benefit just as well, if not more, from SGLT2 inhibitors. So it's a little inconsistent what I'm saying, because the data would suggest that this is reversible and they still benefit even if they drop in terms of their GFR, even the CKD benefit. However, me being a relatively conservative endocrinologist, maybe timid, I hate to see patients cross GFR categories. So if you render them from CKD 3 to CKD 4 because they dropped more than expected, I just don't like the way that looks. So I tend to stop the SGLT2 inhibitor if the GFR fall is more than 15%. I will tolerate 10% or a little bit more. I'm not sure I wait to 20%. Now, this discussion mandates that we're checking the GFR 1 to 2 months after, right? The nephrologists say you should check the GFR. So maybe we shouldn't even check, so it would be under our radar screen, if you will, so that we don't even know. But it's so tempting to check the GFR in 1 to 2 months, which is what I do. Not if the patient has normal renal function, but if the renal function, if the GFR is under 60, I check the GFR in 1 to 2. I know that's not in the package label. I know nephrology experts do not recommend that, but this is what I do in my clinical practice. So maybe I have too much information. But I think that if you don't do that and you check them in 6 months or 12 months and they're down, you have no clue whether this was an abrupt hemodynamic effect, an AKI that developed during that past 6 to 12 months, or whether there's been a slow inexorable decline because the drug is not, flattening out that GFR curve. So I think it's important, but again, not in patients with GFRs of 70 or 80 or certainly 90. These are patients with CKD3 and above. I tend to check the GFR, and I'm fine up to 10. I get a little nervous over 10. I stop it if it's more than a 15. Importantly, we now have another tool for these patients. We all read the FLOW trial, which was a semaglutide trial in DKD. The data are not as robust as with the SGLT2s, admittedly. The relative effect was, I believe, 26% as opposed to the 39% that we get with the meta-analysis from the 3 kidney trials, Credence, EMPA-KIDNEY, and DAPA-CKD. So it's not as large an effect. And that was only DKD, right? FLOW only enrolled patients with type 2 diabetes. So we don't know if this effect would extend to a general CKD population, as we know with the SGLT2 inhibitors. But if you have some side effect that is not tolerable from an SGLT2 inhibitor, or you have a dramatic drop in the GFR from an SGLT2 inhibitor, and you want to stop it, obviously they're on an ACE inhibitor, they're on RAS blockade, but you want to give them something else in terms of a glucose-lowering drug with a renal benefit, then at least now, since FLOW, we have semaglutide, which can be used. So it's not like you're not covering them in terms. Now, of course, once you start the semaglutide, you have to check the GFR as well. Although you don't get this, to my knowledge anyway, in FLOW. I don't think they saw this initial. I may be wrong on that, but I don't remember hearing about an initial dip with the GLP-1s.
Thank you, Dr. Silvio. You have provided very valuable practical insight to all of us. So as we come to close this insightful CME, I would like to take a moment to thank all of you for joining us from 20 different locations across India. This broad participation highlights the collective commitment of our medical community to advancing the care of patients dealing with diabetes, cardiovascular, metabolic disease. A special thank to Dr. Silvio for his comprehensive talk on strategy for managing diabetes, heart and kidney health with the use of SGLT2. Your expertise has enriched our understanding and provided actionable insight that we can apply in our own clinical practices. This discussion today have reinforced the need of aggressive approaches, and I hope we all leave this session with renewed motivation to work together for better patient outcome. Thank you once again. We look forward to seeing you for future events. Stay safe, stay connected, and good night to everyone. Thank you.
Thank you.
Thank you, everyone.
Thank you, Tech Supportive. You can now end the meeting.
Yes, sir. Yes.
Thank you, bye.